I'm Shajit Thomas John. I'm going to talk to you today on trisomy 21, otherwise known as Down syndrome, its diagnosis and management. I'll be having about 4 sessions. The first session will be on Down syndrome, his history, chromosomal basis and the types of Down syndrome, and the diagnosis. The second and third sessions will be on associated conditions and the management in brief. And the fourth session will be on general management, what are the follow-up and the recommendations that are in place, and the future of the treatment and management of Down syndrome. So Down syndrome is one of the most common genetic causes of moderate intellectual disability. The incidence in live births is approximately 1 in 733 or 1 in 800. Incidence at conception is more than twice that rate, which is accounted by early abortions. Though there are a large number of incidents occurring at birth, the abortions will reduce it to 1 in 733. Down syndrome is named after Dr. John Langton Hayden Down, who was an English physician and hence the name Down. The nomenclature, it was earlier known as Mongolism, but it was abandoned in 1965 because that gives a racial tune to it. It was otherwise known as Morbus Langton Down. Morbus Down, Morbus means disease. Langton Down disease. Down syndrome with an apostrophe S. Now the apostrophe S has been deleted since 1974 in the US because they believed or they told that Dr. Down did not have the syndrome. Another nomenclature is congenital acromicria syndrome, but what is generally accepted is trisomy 21. But the term now Down syndrome is still popular because everybody understands what Down syndrome is all about. A few usages you should be careful about. Children with trisomy 21 or children with Down syndrome. That is how you should mention it, and not Down syndrome children. So that is something, because the importance should be on the child and not on the Down syndrome. Moreover, it's a condition and not a disease. That is again something we should be careful about, because many people call it as a disease. It's not a disease, it's a condition. And the term mental retardation should never be used. You can call it as a differently abled children, exceptional children, children with special needs, or intellectually challenged children. The terminology that is accepted by the government is intellectual disability, which is popular in all the government recordings. Now coming to the history of Down syndrome, the first description was made in 1838 by Jean-Étienne Dominique Esquerel, and later in 1844 by Edward Swegon. John Langton Hayden Down published a more elaborate description in 1866, and that is how it came to be known as Down syndrome. And the chromosomal aberration was discovered only in 1959 by the French human genetist Jérôme Louis Marie Lejeune. Now, this was a publication given by Dr. Down, Observation of an Ethnic Classification of Idiots. That is how we published it. And later on, there's a lot of controversy to the term of ethnic classification of idiots. Now, coming to the maternal age and Down syndrome, the incidence of fetal trisomy is directly related to the maternal age and parity of the mother. For a 25-year-old woman, the risk of having a child with Down syndrome is 1 in 1,300, even though the general risk is only 1 in 733. At 35 years, the risk increases to 1 in 365, and at 45 years, the risk is 1 in 30. Advanced maternal age, history of abortion, and/or bleeding in pregnancy are risk factors for the birth of a chromosomally abnormal child. Now coming to chromosome 21, that is where the whole thing lies. It depicts 1 to 1.5% of the human genome. It's the smallest human autosome with 48 million nucleotides. There are about 350 to 400 genes on chromosome 21, and these 350 to 400 genes are responsible for the manifestations of Down syndrome. Now, there are three types of Down syndrome. One is a non-distinction. 95% of cases there are 3 copies of chromosome 21, as is mentioned in the books. Though in Kerala, we have found it to be different. It's only about 89%. The origin of the supernumerary chromosome 21 is maternal in 97% of cases. And majority of these occur in the maternal meiosis, about 90%. Now, this is chromosome 21. As you can see here, there are 3 copies instead of 2 in all the other chromosomes. This is a translocation, Down syndrome. It involves chromosome 21. The fusion at the centromere between chromosome 13, 14, 15, 21, and 22. Now, translocation of a 21 chromosome, where the 21 part is translocated onto the 21st chromosome itself, there's a 100% risk for a chromosomally abnormal child, except in de novo cases. If it's a de novo case and if it's 21, there need not be high risk as 100%. T1421, where the 21st chromosome is on the 14th chromosome, that has a risk of 5 to 7% when it is transmitted by females. Now, the picture that you see is a 14th chromosome. Here you can see it above. The part of the 21st chromosome is lying on the 14th chromosome. So that is known as a translocation Down syndrome. We also have the mosaicism. Some cells have 46 chromosomes, others have 47. Whereas all the chromosomes, all the cells do not have 47 chromosomes. Some are normal with 46 chromosomes. This is because an aberrant zygote can lose one of the 3 chromosome 21 of a pure trisomy in a portion of the cells, and that can lead on to a set of normal cells. Alternatively, the zygote can have a normal karyotype, but in a post-zygotic mitosis, non-distinction of chromosome 21 takes place. So these are 2 conditions, 2 ways it occurs. One is a chromosome, after the 3 chromosomes, 1 is lost. The other one is a post-zygotic state. There's a non-distinction after there is mitosis. Now, structural aberrations of chromosome 21 as mosaics are always caused by post-zygotic rearrangements. In case of mosaic Down syndrome, 100 metaphase cells should be scored to confirm that it's a mosaic. Now, this is just what I've explained. Trisomy 21 is a trisomy of 21. There are 3 chromosomes in the 21st one. And this is a translocation where a part of it is lying on another chromosome. Here it is depicted as 14 chromosome. And this is a mosaic where you have a trisomy 21 and you have a 2 chromosomes of 21. So you have a normal set here and you have an abnormal set here. Now, coming to the diagnosis. Diagnosis is basically by gestalt, which means you look at the patient and then make a diagnosis based on the various features that you say. You don't go into them one by one. You see a person and you know it's somebody who the person is. Similarly, you see a child with Down syndrome and you know, for the trained eye, you know it's a case of Down syndrome. But it has to be confirmed by a karyotype. Now, the clinical triad, what is normally told is there's mental retardation, hypotonia, and a typical facies. Now, this typical facies is difficult to say because there are more than 100 individual features. And all these features need not be present in all the individuals with Down syndrome. But the diagnosis is difficult at birth, even though you have a triad like this, because the typical facies are variable at birth especially. What you can see is a mid-facial hypoplasia. And the intelligence is not accessible at birth. So the most important feature at birth could be just a hypotonia. And there are a lot of conditions where you can have hypotonia. So thus, we have the Hall's criteria for diagnosis in the newborn period, where there's hypotonia, poor motor reflex, a flat face, upward slanted palpebral pressure, small dysplastic ears, hyperflexibility of the joints, short neck, redundant skin, short 5th digit with clinodactyly, single transverse palmar crease, and pelvic dysplasia. You may not get all these things, but then this is the Hall's criteria for the diagnosis of Down syndrome. Now, this is a child. You can see the upward slant of the eye. The ears are low set. and you have a hair, just straight hair, and see you have the mid-facial hypoplasia here, the low set ears below the eye, a flat occiput, and straight hair. Now this is a pictorial representation where you have the epicanthal folds, upward slant, small low set ears, a flat facial profile, and short neck with excess skin over here. And in the feet, you have the sandal toe deformity where you have a sandal gap, and the hand you have the single transverse crease or single palmar crease, and the hypoplastic inward finger, the clinodactyly. Of course, the brush field spots, it is easier to identify in the light-skinned people in our country. It may not be that easy. So the confirmation is by cytogenetic analysis. The question is whether it is needed. When you can make a diagnosis by Gestalt, you can make a diagnosis by looking at the characteristics, and then should you subject the child to a further prick, blood checkup, and the cytogenetic analysis. So is it needed? Yes, it is needed. Why? Essentially, to confirm the diagnosis, that is the case of trisomy 21, and then it's essential to know the type of the trisomy 21. It could be a translocation Down syndrome. Then we should have the parents checked, for the risk is very high in future pregnancies. As mentioned earlier, if it's a 21-21 translocation, then the risk is 100% if it is not a de novo translocation. This also depends on the type of translocation and the sex of the carrier parent. Mosaics, though phenotypically similar, have a better outcome depending upon the percentage of trisomy cells and the site of involvement. Now, what I have mentioned, the karyotypes, there are three types. Non-distinction, where you have 47XX plus 21 or 47XX XY plus 21, male or female. The translocations on 14, 13, 21, and 22. And the mosaicism, where you have 46XX, a normal set of cells, along with 47XX plus 21, where you have a trisomy cell. So it's a combination of normal and abnormal. If it's a male child, it's 46XY with 47XY plus 21. So that's the end of session 1.